Well, once again, big thanks to Charles for the invitation and for giving me one of the most exciting talks for me on technology and direct anterior hip arthroplasty, and acknowledgements to Roger Quesada, my fellow at American Hip Institute. My disclosures are listed with the AAOS, and one important disclosure is that alongside the late, great Larry Dorr, I was on the original design board with Larry and Stefan Kreutzer and Doug Paget with Mako far before they were acquired by Stryker, and we worked on the development of the original technology together, and were amongst the first to do the Mako robotic hip replacement. So I'll share my journey with regard to robotics, but I'm not married to any one technology, and more broadly, I'll speak to some of the exciting technologies I think are coming down the pike. Now, before we get into technology, it's important to acknowledge that total hip replacement is perhaps the greatest operation ever invented. So lucky us to all be here and to all be surgeons who do this operation. So anything we talk about in this talk is really making a good operation into a great operation, or a great operation even better than it already is. So with that said, since it's already great, how can technology help humans? It may help us with accuracy, with reproducibility, and with efficiency. What are the arguments against using technology? And we've all heard these. So I've been doing it this way for 30 years. My results are already great. I don't need no robot. I'm just too good. But I think to innovate requires us to say that however good we already are, maybe we could be better. So the innovator's dilemma is that it requires a certain amount of humility for us as surgeons to say we're not as good as we possibly could be, and maybe there are ways to be better. There are also ways to be worse, and technology hasn't always helped us. It goes back as far as 1980, and there have been some twists and some turns. Fluoroscopy is a technology, and I think everyone in this room has used fluoroscopy in their DA approaches. Some of the early uses of it require overlays and things like this, and drawing with markers, and there have been many technologies that have supplanted a lot of that, but fluoroscopy clearly helped. And so it's a really important technological innovation, really specific to DA approach over historical posterior approaches, that helped with cup position, helped with leg length discrepancy, helped reduce the outliers in our field. But X-ray and fluoroscopy are two-dimensional, and we as a field of orthopedics have been limited a little bit by this over the course of our history. Traditionally, we've judged our accuracy with X-rays, and we're using a 2D perspective of a 3D object, and as the good Prince is demonstrating here, that can sometimes be deceptive. So navigation, there's Imageless, there's Fluoro-based, there's CT-based. The point of navigation is to allow intraoperative assessment, ideally in the third dimension. There's fluoroscopy-based navigation, where you take a two-dimensional image and extrapolate three-dimensional information, such as cup version. The first generations of navigation, which were imageless, helped with cup placement, helped with accuracy, and it was concluded that they may contribute to improved long-term outcomes. Second generation CT-based navigation further improved cup accuracy and helped with better preoperative planning. We can plan in 3 dimensions. That's an important ingredient. We might preserve more bone, and we may have greater accuracy in leg length adjustment and hip offset. And then robotics, there are a couple of robots that are available on the market today. The Mako robot is the one that I mentioned I've had the most experience with. And so I'll kind of take you through this journey, and then we can think about what the future may hold. The goals of robotic assistance from the start were 3D virtual pre-op implant planning, intraoperative guidance, giving us information on combined version, hip length, and hip offset, and then navigation for the neck cut and for the femoral version. So a lot of information here. This starts with intraoperative registration and plan execution. This is CT-based, so we have a 3D virtual model. I tell a patient it's like a CAD model, and this allows us to personalize the plan into their hip and pelvis in the third dimension. And then live surgical assessment, which gives us feedback as we're doing the procedure, as we're implanting the cup, and as we're implanting the trial stems and reducing them. And so lots of information here. What does this add for us? So the robotic-assisted THA facts are clearly we get more information. We have information intraoperatively on the cup version, on the femoral version, both the native version and the component version, leg length and offset, both pre and post-operatively, compared to pre-op and compared to the contralateral side. Preoperative 3D virtual planning. I think this is a big deal, being able to plan in 3 dimensions. If you think about cup sizing, we've traditionally sized the cup on a template of an X-ray, which is essentially a coronal view. Now I really size the cup based on a transverse view. So we're looking at the anterior and posterior walls and looking at what cup size is going to fit best between them while not taking unnecessary amounts of bone. Robotic execution. This can help us with our accuracy of executing our 3-dimensional plan. And finally, navigational confirmation of our final reduced product. So what does this actually do for us? I'll walk you through our data from American Hip Institute and what we've learned. We found increased accuracy of component placement with up to 94% reduction in outliers, depending on which of our studies. One of the wake-up calls maybe for all of us in the field was Callahan's study. Great institution, Mass General, great surgeons, and they found that roughly half of their cases were not in the safe zone. And of course, we can debate whether there is a safe zone that applies to all patients, but the fact of the matter is the surgeons at the time were aiming to be in the safe zone, and they weren't in the safe zone half the time. So while we can debate what should be a safe zone for an individual patient, I think we would all agree that we would like to be able to get our components in the position we think we're getting them. And if we can have more information and more accuracy to execute the plan that we want to execute as surgeons, then that can help us. So back when we started doing Mako robotic guidance, again, this is far before the Stryker acquisition, I actually wasn't sure that it was going to increase our accuracy much. So we did our first study on it. We published in Core in 2013 on cup placement using freehand technique versus robotic guidance. And this was sort of a replication of the Callahan study, but comparing 2 groups now, comparing robotics to conventional THA. And we found what now we would all expect, which is that we reduced the outliers. And essentially everybody was in the safe zones. We then did a larger study with my previous partner, Dr. Alden, who I think is at the meeting somewhere. And we looked at nearly 2,000 hip arthroplasties in our group and compared Mako anterior, Mako posterior, fluoroscopic guidance, traditional X-ray guidance, and navigated, and found that the accuracy, again, was highest for the robotic groups. Both the anterior and posterior robotic groups had the highest level of accuracy for cup placement. And then subsequently in our 2019 publication, looking at over 500 robotic replacements, showed more of the same. More cases inside the safe zones, fewer outliers, and some of the patients who were outside the safe zone were intentionally outside the safe zone because we didn't think the Callahan safe zone applied for the particular patient's anatomy. So it's more accurate. Is that enough? I think we could get on to some more. There's better bone preservation, and this is due to accuracy of bone preservation. We did a volumetric analysis of how much bone we were taking from the pelvis and found that we take less bone. And that may not matter in the primary situation, but it may matter in the revision situation, because 20 or 30 or 40 years later, if a patient requires a revision, if they had better conservation of bone in the index procedure, that may help with the revision and help avoid bone loss, pelvic discontinuities, et cetera, et cetera. And functional outcomes. Okay, it's more accurate. Does that matter clinically? So we've looked closely at this. First in our study we published in 2018, this was 85 robotic compared to 85 non-robotic. These were propensity matched and minimum 2-year follow-up, so short-term follow-up matched by age, gender, and BMI, and found that the robotic group had significantly higher Harris hip score and forgotten joint score. The forgotten joint score being an important metric because another thing that has plagued us as a field is the ceiling effect of our patient-reported outcome metrics. Very hard for us to tell between good and great, or between great and even more great, when we're using a Harris-Hip score and everybody's got a score of 100, right? The forgotten joint score has helped us because the goal in the forgotten joint score is to have a hip replacement that feels so good the patient forgets it's even there. And with that in mind, the robotic group were more than twice as likely to feel like they had a normal hip. So that really helps us distinguish between a great operation and an even greater operation. We subsequently published the 5-year outcomes, again, propensity matched. This was 66 patients per cohort, and found basically similar things. The robotic THAs reported higher patient-reported outcome scores. And recently, at last ACUS, presented our long-term greater than 10-year outcomes, and this will be forthcoming in print. And here are 57 hips in each group, and found a trend in favor of robotic THAs with respect to the PROs, even at 10 years, and higher rates of meeting clinically significant thresholds. This is 10-year follow-up. 4 times less likely to have acetabular implant placement outside the Callanan safe zone, and comparable survivorship and complication rates. So a lot of data there on accuracy and functional outcomes and bone preservation. Is it cost effective? This is clearly a concern. These technologies and all the other ones we'll talk about toward the end of the talk do cost money. You may be thinking, I'd love to use technology, but my hospital or my surgery center won't pay for it and it's too expensive. These technologies are effectively cost effective. We did a cost effectiveness analysis with a Markov model analysis published in JAOS on robotic assisted, and found that manual total hip replacement is actually more costly than robotic assisted THA from the payer's perspective in both Medicare and private settings. Now, this is societally speaking, right? Understanding that the facility may still have to bear a cost, but it is saving a cost to society. So we need to marry societal cost and facility cost at some point, and the facilities need to get recognized for the value that they add in preventing reoperations and complications that increase cost to society. So what are future directions? There's a lot of interesting technology coming down the pike. Virtual reality, augmented reality married with robotics, AI. We just heard a fantastic talk. Thank you for that. Really stimulating thoughts in AI. And it feels like we are just touching the surface of what is possible. So far, augmented reality has shown in pelvic models that there's more accurate cup placement, and it's faster and easier than fluoroscopic guidance. So this is an exciting realm. CT-based navigation systems with AR enabled surgeons to place a cup more accurately in this study than was possible by freehand placement. Artificial intelligence is starting to get married with some of the technologies. OrthoGrid is an open platform, and this is based on intraoperative fluoroscopy. So now you're marrying fluoroscopy with AI. So far, there hasn't been a difference in this study between human inputs and automated AI based on fluoroscopy, but it stands to reason, particularly in light of the preceding talk, that AI is going to get better than we can possibly be, and it's going to help us. So in summary, there's a lot that we can do already with technology, and I think the future is bright for us. We are all very fortunate to focus at least part of our practice on one of the best operations ever created in the history of medicine. And we're in an exciting era where that great operation is getting even greater, and we can strive for the very best surgical outcomes. Part of that is by optimizing component placement, and it's clear that technology can help us now and will probably help us in the future. We can preserve and restore the normal anatomy, and we should strive to maintain native biomechanics. And ideally, we can do this with no increased cost to the payer in a manner that's cost effective for society. Thank you very much.